Hi, everybody. Aki Smith here, founder and executive director of Hope for Stomach Cancer and caregiver to my father, who was diagnosed with advanced stomach cancer in 2013. Thank you so much for being here on this webinar called How Blood Technology is the Future. I am very excited and I am very hopeful in the progress that is happening right now in this space. And I hope that we can learn together about some of the things that are being offered now and some of the things that might be offered here in the near future. So before we begin, I just quickly wanted to share some of the free resources that we offer here at Hope for Stomach Cancer. Our vision is to bridge the gap between research and patient care. So we have a few resources that we have on our website. One is a Hope in a Bag free navigational kit. It comes with a companion guidebook and NCCN guidelines, as well as other resources. We have two support groups that are happening every Monday, twice a month. One is for stage 4 support, which is with GI oncologists, and this is inclusive for GI upper GI cancers such as esophageal cancer, GI junction, and stomach. And then we have one just exclusively for stomach cancer, which is with a GI oncologist and rotating surgeons that volunteer their time. And it's great resources to hear about other stories and see how we can connect. We also have our private closed Facebook group, which is stomachcancersupportfb.org, which is also an amazing space to share privately kind of some of the things that you're going through, and it's all experience-based. Then we have our Hope webinar. So we have this one, and then we'll be offering another one in a couple of weeks, which is all about patients, for patients and caregivers. Of course, you could just sign up to our newsletter, and there you'll have everything in one email about everything that's going on, and that's once a month. We do not spam. Lastly, we've been doing Hope Stories for Stomach Cancer Awareness Month. So you can now go onto our website, and we've got all the stories on our website, and including one that we're sharing today. She's also has a different video for her Hope story. But before we begin the webinar, I really wanted to introduce to you our patient story, which is Camilla Row. And here you go.
I'm a clinical psychologist. I'm non-practicing. I haven't practiced in 8 years, but I do have a research background. So I do read a lot of studies and a lot of press releases from pharmaceutical companies just on what's coming out, what new therapies are being released. I think I'm able to digest the information a little bit better than the average person just because I have been reading so much scientific literature my entire adult life. The first time I was diagnosed, it was June 2018. And then my recurrence is February of 2022. I went from being stage 1B after my gastrectomy to stage 4. In my mid-30s, I started feeling heartburn persistently. I was young, I was active. I watched what I ate, but I had persistent heartburn, and I went to the doctor several times. It took me 2.5 years to finally get an endoscopy. The gastroenterologist tells me it's highly suspicious and concerning for gastric cancer. We need to do a repeat endoscopy right away to confirm the findings. And I did that about 2 days later, and they confirmed that it was stomach cancer indeed. And I was 39 at the time. My kids were 3 and 5. In a whirlwind, I got diagnosed June 1st. On July 2nd, I was having my complete stomach removed. He lets me know the pathology comes back with 2 of the local nodes positive for cancer. So I did 8 rounds of FOLFOX. I want to say about 3.5 years, I continued to be no evidence of disease. The kind of cancer that I have, which is the signet ring cell carcinoma, it's a poorly differentiated cancer, and it doesn't form nice tumors. It's kind of scattered, and the analogy you hear a lot is it's like throwing sand across the floor. So with that kind of aggression, we thought we need to be that aggressive with surveillance. So we added ctDNA which is circulating tumor DNA monitoring. And so I had been getting Signatera tests every 6 months as a part of my surveillance. But last July, I got my first positive one. So this is considered real cutting edge stuff because it can just pick up on the smallest amounts. And it is showing a high correlation between a positive test and a future recurrence. The only thing is you just don't know where that recurrence is going to be. I was kind of bracing myself for something to pop up. In December, when I had my routine CT scan, Dr. Hiyama called me and told me, we found some soft tissue masses on your ovaries. We don't know what it is, but I have seen this a lot in the younger women who get gastric cancer, having it metastasized to the ovaries. Did a biopsy confirm that it was actually Krukenberg tumors, ovarian masses of gastric origin. And in a few days, I was having emergency surgery on a Saturday to get that removed. Once I had my ovaries and my fallopian tubes removed, we started on FLOT chemo, which is the most aggressive first line for gastric cancer there is. And I also started with Opdivo, which is immunotherapy. Being a stage 4 patient, I just kind of have to take anything I can. Like, I don't have anything to lose, and I'm healthy enough where I feel like I can try different things. During the 4th lot, I was working really hard to get myself HIPEC, which is where they pour the heated chemotherapy medications. They pump them into your abdomen, and then they let it circulate for about 2 hours, and then they suction it out. And I was able to do so after getting a lot of pushback from oncologists saying there's no proven benefit. It could give you, there's more risk than benefit, like it can damage your organs. It's a newer therapy, and I know there's a lot of controversy on it, but I think a lot of the newer studies are showing how it could benefit people with peritoneal disease. I'm very numbers driven, I'm very fact driven, so I like to do the research and see what comes up. And what comes up, sometimes I don't like seeing what comes up, they're not favorable, but I also feel hopeful that something's gonna be right around the corner. I feel it, whether it be CAR-T or some other newer therapy that we haven't heard of. I'm feeling hopeful that there'll be something for gastric cancer real soon. My other hope is I hope people can look at us and see that we can live productive, healthy, happy lives and manage this like chronic disease.
Welcome. I'm Dan Catenacci, a GI medical oncologist, and today I'm joined by Adam Jury from Natera to talk about the Signatera test, and Philip Munson from Mirexis to talk about a test for early detection. It's a pleasure to be here today, and I'm going to speak for the first 30 minutes just to provide a background of blood technology, and then we'll lead into those two discussions. A few words. I'll talk for the first 30 minutes, and then each of them approximately 15 minutes each. And then after that, we'll have a question and answer session. There were some questions pre-submitted, and I will try and address those along the way. And certainly we can get to them afterwards. And I will be speaking quite quickly because there's quite a lot to cover so that we really understand, before we even get to cell-free DNA testing, a whole bunch of things that we really need to understand. And so I'm going to start with gastroesophageal cancer background and then talk about molecular profiling in general, particularly in the tissue first, and then get to the cell-free DNA. And so don't fret, this will be online and you can always go back to it if it's coming at you fast. There's a lot of information, and certainly we can clarify things afterwards with questions. So without further ado, I'm going to start my clock so I don't go over. And background on gastroesophageal cancer. So you can see there the incidence and mortality of gastric cancer and esophageal cancer. Esophageal cancer is made up of adenocarcinomas or squamous cell, and you can see the vast majority are adenocarcinomas. And worldwide, this is a really significant problem. Taken together, gastroesophageal cancer is the fourth highest in incidence and the second highest in cancer mortality. So clearly a significant problem. What are some risk factors? There is a known genetic predisposition. You can see a number of listed familial diseases there. And one of the pre-questions was, are there DNA tests that can predict risk for stomach cancer? And the answer is certainly yes. You can see that a certain subset of diffuse type gastric cancer can be caused by an inherited problem in the ECADHERIN gene called CDH1. It's not common, but it certainly is possible. And another one that will come up through the talk is HNPCC, which causes MSI high tumors, and we'll get to that as well. And you can also test for that in strong family hit risk. However, genetic predisposing factors cause less than 5% of all gastroesophageal cancer. The vast majority are caused or associated by things that we are exposed to through our lifetime. And so distal gastric cancer is associated with H. pylori infection and other carcinogens, and proximal or G-junction esophagus adenocarcinoma is associated with chronic reflux, Western diet, Caucasian, obesity males. And again, this is the one that's increasing in incidence, while stomach cancer proper has been decreasing in incidence. When I talk about gastroesophageal cancer, then it's really three main subgroups. Esophageal squamous cell, we're not going to focus on today. And really, esophagogastric junction adenocarcinoma and gastric adenocarcinoma, I refer to as one entity, gastroesophageal adenocarcinoma. And in fact, treated the same, both in the metastatic setting and for me, even in the perioperative setting. That said, we recognize immense heterogeneity within this disease, gastroesophageal adenocarcinoma. There's heterogeneity of diffuse type and intestinal type. There's heterogeneity from the proximal site to the stomach site. And there's definitely genetic and molecular heterogeneity. Shown here, there are four major subcategories of gastroesophageal adenocarcinoma color-coded. And you can see their incidence differs from the proximal site to the distant site, and that's shown here in these two columns, where the proximal site is predominantly chromosomal instability. The other thing to note is that these incidences are by stage 1s to 3, and that the incidence actually change in the stage 4 setting. For example, MSI high tumors are really a small subset of gastric cancer, but these are all important factors that we take into account when talking about this cancer type. Now, we stage cancer and gastroesophageal cancer in 4 categories, and the reason why we do it is because it helps with prognosis and therefore will tell us what the best therapies are. And you can see that gastric cancer on the left and esophageal on the right, the incidence is based on the SEER database. A large proportion, majority of patients present with advanced disease, either stage 2 or 3, which is called locally advanced, or stage 4 or metastatic. And the reason why that's important, as I mentioned, is because that dictates outcomes. And these are statistics, everyone's different, but when you look at statistics, you can see that clearly localized cancers like stage 1 do better than distant cancers. And that said, you heard even from Camilla's story, even if it's stage 1, there's still a risk factor that it could recur. And so these stages then dictate treatment, and you can see that surgery is reserved for stage 1 and 2 and 3, and stage 4 cancers generally are not offered surgery, but rather palliative therapies. And because the risk of recurrence is so high in the locally advanced stage 2 and 3, that perioperative therapies are offered to try and decrease that risk with curative intent. So for today, molecular tests can be applied both in the stage 4 setting, but also in the perioperative setting to less degree, and we'll get to that. So with that background, let's talk about cancer and understand what it is. So what is cancer and why is there cancer? So cancer is a mass of abnormally dividing cells that are continually dividing uncontrollably and inappropriately. And eventually, wherever they start, in this case, the stomach or esophagus, they will start to invade locally and then distantly. And the reason why we get cancer, there's either known factors or associated factors. We talked about genetics that you inherit, and also exposures to carcinogens and lifestyle factors like sedentary lifestyle, high-fat diets, etc. In order to understand cancer, though, we have to understand what's normal. And so when you look at the stomach, and if you were to take a cross-section and blow it up, this is what it would look like from the inside to the outside, and it's a layer, like an onion layer, of different layers of tissue. And the inner layer, this one here, is called the epithelium, and it's made up of cells. Each one of these blocks is a cell, and the dot is the nucleus. And this is what's normal. It's thought that cancer cells originate from the crypts in this epithelium, and it is known that these cancer cells under the microscope look different from normal cells. And so a pathologist looking at a cross-section of normal versus abnormal would be able to see these abnormal cells that started here and then started to invade downward into the stomach lining, and eventually will start to spread. You can see there's a lot of normal cells in the vicinity, neutrophils, macrophages, lymphocytes not shown here, that are our immune system trying to stop this, but eventually these cancer cells can evade that process. This is what the pathologist sees under the microscope. And so we have intestinal type, we have diffuse type, like you heard from Camilla. And this is sort of simplistic, where the World Health Organization pathologists recognize at least 14 different morphologic subtypes of stomach cancers when they look under the microscope. So the other part of this that we'll get to a little bit of detail is to really understand molecular testing, is to go back to Biology 101 and the central dogma of biology that all living organisms obey. And that is that the DNA is the blueprint of life. And that blueprint is coded by base pairs in a specific code. And this DNA resides inside the cell in the nucleus. And the DNA is transcribed into RNA, messenger RNA, which then comes out of the cell and goes to this Golgi apparatus where it's translated into protein. And so 3 base pairs will specifically encode a one amino acid. And this specific chain then dictates what the protein is. And so liver genes in a cell will be turned on, transcribed, and made into proteins, and those proteins do liver functions. Stomach genes will be turned on, transcribed, and translated, and do stomach-related things. And so that's how you think about the normal biology. And the other thing to note is that cells need to divide. They divide and replicate the DNA so that it's exact match in its daughter or sister cell. We divide our cells when we're babies because we're growing and we need to increase mass. And then in the adult, we still have regeneration of tissues to replace older ones that are dying. If we get a wound, we have to heal, but then it turns on and off appropriately. And so to really get to the sense of this, there's 6 billion base pairs in the human DNA, of which there's around 20,000 genes, less than 1% of all the DNA. And they reside on 46 chromosomes, 23 from mom, 23 from dad. And we should have 2 copies of every gene in every cell. So with that background, why is there cancer? Well, cancer is a problem with that DNA code. And one major problem is that just as you're replicating your cells, because there's so many billions of DNA copies that need to be made of those base pairs, you can just make a copy error. And these random mistakes can lead to an acquired, what we call somatic gene alteration that leads to cancer. In addition to that, we talked about you could inherit a problem in a gene, and that would, of course, accelerate this process and shift it to the left in terms of getting things done at an earlier age. And in fact, some genes, like mismatch repair genes, go and repair these random copy mistakes. So if you lose the capability of that, say by inheriting it, then of course you're going to get all kinds of mistakes that aren't proofread and get accelerated towards cancer. And then finally, it's well recognized that exposures to various risk factors, carcinogens, radiation, viruses, et cetera, can accelerate these changes of DNA over time. So together, and often there's multiple things going on that contribute to the development of cancer. Okay, so now molecular profile. So with this understanding that DNA goes to RNA to protein, we can then test to see what are the problems in the genes in a given cancer cell. We can test at the level of DNA, which is called gene sequencing. We can test at the level of RNA, or we can test at the level of the protein with something that's called immunohistochemistry, the pathologist does. And so it's important to note that some problems in some genes can be assessed both at the gene level or at the protein level. So an example is, you've heard of HER2, gene amplification. Gene amplification means you have, instead of 2 copies of HER2 in every cell, the cancer cells has multiple copies, hundreds of copies sometimes. And so you can sequence the DNA and find that. Alternatively, as a consequence of having so many copies of the gene, you get more RNA of HER2 and more protein of HER2. And so this huge overexpression you can test for with IHC and identify it that way. So you can do either way. On the other hand, some biomarkers can only be tested at the protein level. An example you've well known is PD-L1. PD-L1, if you were to sequence the gene, is normal, but it can be overexpressed, and that's what we're looking for. So you would have to do IHC. So going forward, if we're talking about blood-based tests later, blood-based tests are being done with gene sequencing. And so we're not going to get information about PD-L1, and that's a common question. So you would have to test that separately. Okay, and then lastly on this slide, traditionally gene sequencing in molecular testing is done on the tumor tissue, a biopsy or surgical specimen. But of course, we can do it from the blood, and we'll talk about that. So there are 4 types of genetic problems that happen in the DNA. And the way we think about it is that there are oncogenes, or the gas pedal in the system, or tumor suppressors, which are the brakes. And in cancer, oncogenes are overactive inappropriately, and tumor suppressors are lost through these genetic events. And so a point mutation or single nucleotide variant is a change of just one of those codes that then leads to a problem, either overactivation of an oncogene or loss of a tumor suppressor function. We talked about copy number changes, and then gene rearrangements, where a gene can get fused inappropriately to another gene and create an oncoprotein. And so the different types of genetic events, you can see the incidences of what you might expect if you look at large samples. The most common type of genetic event is a base pair change, but close second is gene copy number changes and amplifications. And that's relevant to this disease because CIN, the purple subgroup, is a huge component of adenocarcinoma, as you can see here. And that's a hallmark, is gene amplification, like HER2, is mostly occurring in the chromosomal unstable subgroup, as are a lot of other genes that are amplified, like EGFR, FGFR2, and MET. So it's suffice to say, why do we do molecular profiling? Well, one of the main reasons is to identify genetic targets that we can go after with targeted therapies. And the classic example here is HER2 gene amplification, where again, you have more copies of DNA that have HER2 gene that leads to more protein. So you have a ton of HER2 protein at the receptor, and it's inappropriately signaling through a lot of other molecules for the cell to grow. And so we have a bunch of treatments like trastuzumab Herceptin, small molecules, TDXD, which is a targeted smart bomb of a cytotoxic agent to Herceptin, to try and stop this cancer cell by leveraging the amount of HER2 protein that's at the receptor. How do we test for these 4 main subgroups? Well, historically, there were what are called low throughput assays that would test for one gene problem or protein problem at a time. So capillary sequencing or Sanger sequencing, FISH, fluorescence in situ hybridization, to look at fusions or amplifications, or immunohistochemistry to do one protein at a time. But as I'll show you, this has become impractical because there's so many different genes that could have problems. Trying to do these things one at a time doesn't make a lot of sense, and often there's not enough tissue to do that. So these single gene markers have their limitations. And what came along next were called hotspot panels, which looked at a bundle of a certain number of genes. Think of maybe ESPN Plus, Hulu, and Disney Plus being offered as a bundle right now. And so it's better, but it certainly doesn't offer all the channels. And so the ultimate bundle is really to do what's called next generation sequencing to get all the DNA changes all at once in hundreds of genes at a time, 300, 400 genes in many panels. And so this is the most economical way, time efficient way to get all this information. So that's summarized here, that the top will get all the different types of genetic events that you're looking for with next generation sequencing, as opposed to hit or miss with hotspot bundled panel. Some examples of NGS panels that are out there commercially you've heard of are Foundation One, Tempus XT, Caris, MyTumorSeq, and you'll hear later about Altera. Okay, so that's molecular profiling. So why bundle? Why not do one at a time? Well, the main reason is because what used to be called, say, lung cancer or gastroesophageal cancer, in this case, lung cancer, was lung cancer 20 years ago. Now we refer to it as EGFR mutated lung cancer or KRAS mutated lung cancer, etc. And the relevance of this is that this interpatient heterogeneity, every patient is different, has in many cases a matched targeted therapy that could be used that we know can improve outcomes. And this is not unique to lung cancer. We look at gastroesophageal adenocarcinoma not that long ago was called that. But of course, now we recognize many molecular subgroups that, at least in the green boxes, have possible targeted therapeutic options. And in green, we have the ones that are FDA approved. And in dark black, we have at least commercially available through other approvals in other tumor types, so we could get access to them. And in some cases, there are drugs that are in development and not available yet unless it's in a clinical trial. The other thing to note here that this is only looking at the genes, not the proteins. So for example, we talked about PD-L1. That chart does not encompass PD-L1 results. PD-L1 has to be done on the tissue through immunohistochemistry, as I mentioned, and that's looking at the expression on the tumor cells as well as infiltrating lymphocytes in the tumor biopsy. And the score, the combined positivity score, CPS, is an aggregate of all positive cells over the total number of viable tumor cells, and that will give you the number. So to give a sense, the incidence amongst gastroesophageal adenocarcinomas of a combined positivity score of 1 or higher is about 50 to 60%, and above 10 is about 10 to 15%. And of course, this is important because almost every study shows that these immunotherapy drugs are most effective, if not only effective, in the higher levels of PD-L1. Okay, another example that's going to be on the horizon is Claudin 18.2 because of a recent spotlight study declaring that it was positive. So we can bet that this is coming to us, and we're going to be testing for Claudin by immunohistochemistry protein expression, because about a third of patients will have overexpression of that. But if you sequence the DNA is normal. So you need to do IHC, and you're not going to get this result from a tissue-based panel or a blood-based panel. Okay, so that is the gene panel that would give you this sort of breakdown of distribution of genetic events. And then this is what you might see if you were to do it by immunohistochemistry, looking at the proteins. And so this becomes quite complex, and you can see that certain results can only be found from the protein result. The other thing that's misleading about these pie charts is that these aberrations are not necessarily mutually exclusive. And so, for example, you can have, we often see, EGFR amplification and HER2 amplification in the same patient's tumor. And so this gets a little muddied, but you can see how complex this cancer is and how these tests can be used to try and gather information to see what the best treatment options are for a given patient. And so the concept then of precision medicine is we have gastroesophageal adenocarcinoma, but we recognize different subgroups within it. So we profile it with various tests, and we try and categorize patients to get into groups that would then be matched to appropriate therapies. And again, I will tell you that some patients may be eligible for more than one targeted therapy because of what I mentioned earlier. You can have more than one problem. And unfortunately, on the flip side, some patients, after all this profiling, don't have a good target to go after. And so they would be treated with standard chemotherapies without the targeted option. Okay, one last thing to address, a layer of problem to address when you're talking about molecular profiling before we get to the blood. And that is, not only is there a heterogeneity between patients, there's also heterogeneity molecularly within a given patient. And so that's shown here. If you were to take a biopsy from one site, the different colors represent the different subclones of cancer that may have different genetic or protein expressions amongst them. They may have a lot of common problems, but then they may have some unique problems amongst them. And so this is important to understand because it has implications on treatment. So the other layer of heterogeneity, both was that spatial at a given snapshot in time, is over time. So if we treat a patient where we recognize that the majority of the patient's problem is this light blue issue, this light blue mutation, for example, and it's treated appropriately, you may get a response, but over time, you may select for genetic events that are rendering resistance to that given treatment. And so then over time, these become the new problem. And so reprofiling at that time point might help us readdress this issue. So the way I think about this cancer now then is at a snapshot in time, if a patient has stage 4 cancer in the primary tumor and different metastatic sites, rather than biopsying every single site to try and get a sense of what's going on, why wouldn't it be nice if we could just get a blood test to address this and see what's going on? And the answer to that is yes, and that's where we're going to get to the blood. Also, over time, when you have progression and new genetic events that are causing that progression, rather than subjecting a patient to another biopsy, wouldn't it be nice to be able to get a blood draw? And the answer to that also is yes. Okay, so what is a blood draw? In the last 10 minutes, I'm going to focus on the so-called liquid biopsy. So it's a blood draw, and it's typically taken in a couple of 10 ml tubes. And what we're looking for is cell-free DNA that has come from the tumor. Tumors shed DNA into the blood through a few mechanisms, mostly cell death. I'll show you in the next slide. And cells are dividing and rapidly growing, but some of them are dying as that's happening, and they're shedding the DNA into the blood. Now, this is cell-free DNA. There's not a full cell. They're not circulating tumor cells. They're just the free DNA that's ruptured out of the cell. And some important components about this is that the half-life of this DNA in the blood is about 2 hours. So when you take a blood draw, that's reflecting what's going on now in your body relatively recently. And the other really important component thing to understand here is that we all sitting here have a ton of cell-free DNA in our blood that's normal DNA from normal cells, usually our white blood cells called lymphocytes. And so in a patient that has cancer, they will have some DNA that's from their tumor, circulating tumor DNA, but the majority of it's going to be from their normal cells, the normal DNA. And so what we're looking for is this circulating tumor DNA, and that's what you see on the reports is the mutation allele frequency or variant allele frequency is the percentage of the circulating tumor DNA amongst all the circulating DNA. And that's what that means. And you can see that it's usually quite low, even in the stage 4 setting, and it's certainly very low in the post-operative setting that we're going to get to. And so the stage 4 setting has been extensively validated in looking at this sequencing of circulating tumor DNA, and we're going to get to that. And also in the perioperative setting, more and more so, you're going to hear from Adam about Signatera there. And there's a lot of effort looking for, as a screening tool, and to try and identify these cancers earlier that you're going to hear from Philip at the end. And so again, circulating tumor DNA in the blood is really a function of just how much is going into the blood and how much goes out. How much goes in is from cell death and secretion into the bloodstream, and how much goes out is usually degraded in the liver. Again, the half-life's about 2 hours. And there's a really important understanding here is that the amount of circulating tumor DNA that you see in the blood is really related to how much cancer you have in the body. If you have a few little teeny sites, you're not going to have a lot of cell-free DNA in the blood, circulating tumor DNA in the blood. And if you have a ton of sites and big masses, then you're going to have a higher chance of having circulating tumor DNA in the blood. And the faster the cancer is growing and turning over, the more likely you're going to find circulating tumor DNA in the blood. So the other really important aspect is that the timing of when you make this blood draw is important. Around the time of treatments and surgery. If you had surgery and you remove the primary tumor, there's a drop in the amount of circulating tumor DNA that's found. And similarly, if you start active therapy and then you check a blood draw 3 or 4 weeks later, the chances of you finding any circulating tumor DNA is dropped substantially, if not going down to negative. The last thing on this slide to understand is that if you find an abnormality in the blood and there is a mutation or something that's identified, chances are that it's real and that it's not a false positive. So it's got a good positive predictive value. On the other hand, if you don't see anything in the blood, it doesn't mean necessarily that it's not truly there. If you're looking for HER2 amplification, if you don't see it, it doesn't necessarily mean that it's not truly there, but it means that we didn't see it in the blood. And remember, it's related to a lot of these factors. And so it may actually be there, but you're not seeing it. This relates to one of the questions that was pre-submitted, is that if you have a positive test, even at only a very low level, is that important? And the answer, in my opinion, is yes. I mean, we just talked about how even if you find a small amount, the fact that you're seeing it at all amongst all this normal DNA is remarkable, and it's important, and it means that it's there. And so both in the stage 4 setting or the stage 3-2 adjuvant setting has different implications, but I think it's important in both situations. So on the spectrum of early stage to late stages of cancer, the amount of circulating tumor DNA goes up. And so you need high sensitivity assays in all of the settings, but certainly in these early stage settings, you need really sensitive assays to identify it, because we're talking about a few cancer cells and you need to be able to see their shedding into the blood. Some studies have been done to show that different tumor types listed on the bottom here have different rates of shedding into the blood in the stage 4 setting. And you can see here that gastroesophageal cancer has a high rate. Almost every cancer can have identifiable circulating tumor DNA in the overt stage 4 setting. You can see here again, the amount of circulating tumor DNA in the blood goes up. The percentage of patients identified as having DNA in the blood goes up as you go up in stage. And we showed this specifically for gastroesophageal cancer. The more sites of cancer you have, the higher the amount of DNA in the blood. Similarly, if you have had your primary tumor surgically removed and then say a recurrence, the chances of you having high levels are lower than if you had a primary tumor intact. And similarly, the location of where your spread of cancer is makes a difference. Liver and lung cancer spots have higher rates of disease compared to, say, peritoneal only cancer in the abdominal cavity often is completely negative, even with high sensitivity assays. So these are all important things to understand. And to summarize then, there are higher amounts and higher sensitivities of finding ctDNA in the blood if you're at a higher stage, if you have more cancer, if you have a higher proliferation rate, a more aggressive cancer, and the type of cancer and the location, like peritoneal cavity versus liver. And so these have implications in terms of treatment. I mentioned if you have surgery and you remove the primary tumor, your amounts of DNA in the blood drop substantially, often to nothing. Even if there is residual disease, it's really hard to find, as you're going to hear about from Adam. And during treatment, I mentioned, if you start treatment, you might see a spike in the first couple of days because you're killing cells and they're releasing the DNA, but then it goes down precipitously if the treatment's working, and you may not find any. So if you're looking to do a blood test to identify genetic targets to use to target therapy, you wouldn't want to draw the blood 3 weeks after starting effective therapy because your chance of finding that would be really low. And similarly, if you're getting treatment in the stage 4 setting and you have stable cancer, your chances are going to have low or no detectable circulating tumor DNA in the blood because it's working to stabilize your cancer. So the ideal time to check a blood draw in the stage 4 setting is at newly diagnosis, before starting any treatment, or at the time of progression, which is going to give you the best chance to find any problem. Okay, so again, on that spectrum of early stage to late stage cancer, the assays designed to identify that circulating tumor DNA are different. So in the stage 4 setting, I'm going to show you a few examples of case examples of looking at stage 4 assays and how they're used. And then Adam's going to talk about how Signatera is used in the monitoring after removing a surgery and its utility in that setting. And then Philip's going to talk about earlier stage in terms of trying to identify before as a screening tool. And as the last slide I'm going to show before I do a few cases is looking at this if on the scale of early disease to late disease from left to right, and the amount of circulating tumor DNA from 0 to high. As the cancer starts to evolve, eventually, if you were screening with circulating tumor DNA, you'd be able to find it long before you would be able to see it on any scans, and long before eventually there are symptoms. And so if you start therapy, you might get a drop in treatment, say with FLOT, and if you have surgery, you may have a precipitous drop in ctDNA. And then over time, if you have residual cancer there that had spread distantly and was occult, not visible at the time of all of this perioperative therapy, eventually these cells would start to grow and you would be able to see the DNA long before imaging, usually about 6 to 9 months, and long before any symptoms. And then in the stage 4 setting, if you were to start systemic chemotherapy, you might see a drop in the ctDNA, and then over time progression. And if at the time of progression, if you change therapy, you might see another drop again. And so you can use this as a monitoring tool. So in the stage 4 setting, we already use tumor markers like CEA and CA19-9, but you can add ctDNA levels, the amount that is going up and down, to help understand if the treatment is working. And this was a question, a pre-question is, well, how can the ctDNA be so low, but one of these tumor markers so high? And the answer to that is that I get all of these because they can be complementary. In some patients, cancer, only one is high and the other ones are low, and vice versa in the next patient. And so examples of these assays are Guardant 360, Foundation Liquid, Tempus XF, Caris Assure, and then you're going to hear how Signatera can be used to follow the levels, but it won't provide the genetic information like is HER2 amplification present or not in the blood to actually target the therapy. And then in the perioperative setting, we have Signatera, which can be used, one, to look at whether or not after surgery, there's any residual circulating tumor DNA present. If there was, that would obviously not be good because we are trying to cure the cancer. And if there's still tumor-related DNA floating in the blood 4 to 6 weeks after surgery, remember the half-life is 2 hours. So if it's still there, that means there's still cancer present and it's not gone. On the other side, what this graph is showing is that there are instances where there may still be cancer around post-surgery 4 to 6 weeks after surgery, but it's so little that there's not a lot of DNA, enough DNA for even the highest sensitivity assay like Signatera to identify it yet. And so it may be negative right after surgery. But over time, you would be able to differentiate between a cure and a recurrence because it would start rising if it was still present. Okay, so that would be, finally, you could monitor post-operatively and identify a recurrence like with Camilla's story long before you might see it on imaging or long before you get symptoms and a clinical recurrence. Okay, and Signatera could be used for that purpose too. And then lastly, common questions are, how do I order these tests, and what are the costs of these tests? I saw one of the questions was, how do I get molecular testing? The doctor would initiate this. Sometimes pathologists do, depending on which assay we're talking about. And in terms of coverage, it's a complicated question because you can see there's so many different commercial assays and also assays offered from various institutions and academic centers. And they're all, some are approved in certain scenarios, but not others, et cetera. So it's not a blanket answer. You have to ask which assay you're talking about and which scenario you're talking about before we can really answer that question adequately. And we can get to that in the question and answer afterwards. Okay, so I'm gonna have two quick case vignettes about using ctDNA in the stage 4 setting. And so this is one of my patients, 72-year-old, had a G junction adenocarcinoma with liver metastases at diagnosis. Routine HER2 testing by immunohistochemistry protein and FISH by gene copy was done, and both were negative. To be positive, this has to be 2 or higher for the ratio. And so the patient started on routine chemotherapy. In my practice, though, I always order ctDNA, and the reason for that is that molecular heterogeneity within patients issue. And this is the results of the assay, and you can see that HER2, ERB2 is another name for HER2, was amplified. And so there was discrepancy between the primary tumor assay results and the blood. And so in the end, we learned that this is because of this heterogeneity within the patient. And the first question one might ask is, was one of these tests false and wrong? And the answer to that is no. We were able to get a liver biopsy, and you can see the primary esophageal mass was clearly negative for HER2, IHC and FISH, but the liver biopsy was clearly positive for IHC and FISH with a ratio of almost 15. So this is an example of finding a target that you would have otherwise missed. And so when we learned that, we added trastuzumab to the treatment, and the patient had a complete response. These dark spots are cancer in the liver, and there's no more or almost very minimal left only 6 weeks later, and eventually had a complete response over time. And my second case, real quick, is an example of using a blood-based test in the stage 4 setting over time. And so that's indicated here with different time points that are then plotted against each other. And you can see that the allele frequency is changing over time. And the color coding is referring to different gene mutations and problems that change over time. And so this patient is an 85-year-old with G junction cancer. And over time was actually treated with chemo-RT and had no evidence of disease. And so we were just following them. But over time, you could see the DNA slowly rising to the point that we needed to start therapy in July. And you can see that over time, HER2 amplification, when we first saw them after chemoradiation, showed no detectable cancer, but over time started to develop HER2 gene amplification. So the patient was treated with trastuzumab chemotherapy, trastuzumab alone, and had a nice response. But then over time, a different gene emerged as a resistance mechanism, EGFR. And so we adjusted our therapy to an EGFR-based therapy. And over time, this could be an example of how one might tailor therapies based on changes that occur over time. So to summarize then, I've provided a background on what the cancer is, what cancer, the problem is with the DNA, how we profiling it, differences between DNA and protein, and then differences between patients within the given patient at baseline and over time, and then how testing the blood can be applied to either the stage 4 setting or the perioperative setting with different intentions. And then I showed you a few cases in the stage 4 setting. So I'm going to stop there and I stop sharing my slides somehow and get to Adam. There we go. So Adam.
Right. Thank you, Dan. I really appreciate setting up the stage for me with all that wonderful detailed discussions about molecular profiling for cancer. Let me start by saying I'm extremely excited to be here today to discuss ctDNA. As a medical oncologist, all of us are really waiting for this to become more widespread use because we all see it as the next big leap forward in the way we diagnose, stage, treat, and monitor cancer patients. So without further ado, what is Signatera? So we know that every patient's cancer is extremely unique. Almost like each cancer has its own fingerprint or signature, so to speak. So what Signatera is, it's a personalized test that looks at picking up fragments of DNA coming from the tumor or ctDNA in the blood. And the important thing to note that this test is custom designed for each patient's tumor. That allows us to be extremely accurate whenever we're testing to see if there are any fragments of cancer left in the body. It is so accurate that, say, one patient had stomach cancer and at the same time had colon cancer, it doesn't detect both. If it's designed for stomach cancer, it will specifically detect that stomach cancer. So before we go into more details about Signatera, I know Dan talked about this, but just as a quick recap about cell-free DNA and ctDNA. As Dan mentioned, we know that all of the cells in our body are undergoing constant turnover. New cells are being born, old cells are dying off, and then those cells break up and release whatever's inside the cell into the bloodstream, including those fragments of DNA, which we call cell-free DNA. And when it's coming specifically from the tumor, that's when we call it circulating tumor DNA or ctDNA. And also, as Dan mentioned, for the half-life for cell-free DNA is less than 2 hours. For ctDNA specifically, it's usually less than 1 hour, sometimes even less than 30 minutes. So any ctDNA that you're picking up on a test is a real-time assessment of what the cancer is doing in that patient's body at that point of time. As opposed to, for example, waiting for changes on CT scans to happen, which we know, for example, if we radiate the tumor, we need to wait 2 or 3 months before we see that tumor shrink enough on the scan. And also to put things into perspective, 1 centimeter or half an inch of tumor that we're seeing on a scan has 1 billion cancer cells in it. That's billion with a B. So if you're picking up fragments of DNA from a single cell, obviously you're going to be able to detect it way before those changes happen on a CT scan. And the test is so sensitive that we're able to detect 1 DNA molecule in a 20 ml tube of blood. So you don't need to have a lot of cancer DNA floating around for us to be able to pick it up. So like we said, there's cell-free DNA, then there's ctDNA, and we have more normal cells in our body than we have cancer cells. So to be able to pick up that ctDNA, it's literally looking through, trying to find a needle in a haystack. And that's why it's very important for it to be tumor-informed or custom-made, because you're really looking for that signature or that fingerprint, and not just like common changes that you can see in cancer cells, which sometimes we see in normal cells as well. So how do we design Signatera? If you think of the mother cancer cell as cancer starts developing in the body, there are certain mutations that happen in the DNA. And then as the cells divide, new mutations occur and new changes happen. And that gives us this shape here, which looks like a tree on its side. Now, the trunk of the tree, that's where the mother cell mutations happen. So even though more changes happen down the line, we know that the changes that we see in the trunk are gonna be present in the branches and smaller branches down the line. So it doesn't matter how many times the cancer changes down the line, it should still contain those original truncal mutations. And that is what we use to design the Signatera test. So what do you need to design a Signatera test? It's tumor-informed, meaning we do need tissue. It could be a biopsy, it doesn't have to be a surgical specimen. We look at the entire DNA, what we call whole exome sequencing of the DNA of the tumor. We also require a blood sample because we want to use those white blood cells, lymphocytes, as Dan mentioned, to rule out any normal DNA, and that increases the accuracy of the test. After that, you have a test custom built for your cancer, and then any further testing after that is just a simple blood draw. So how can Signatera benefit you as a patient? What questions will it answer? If you had surgery, for example, do you need chemotherapy after surgery? It can show you which patients still have those fragments of DNA floating around and will likely benefit from chemotherapy versus ones who don't have any fragments of cancer, and chemotherapy has shown to be not as beneficial in that case. Then during surveillance, as Dan very beautifully showed on that graph, is the cancer coming back? Can we detect it earlier before it becomes large enough to show up on the scan and potentially in multiple spots? And last but not least, if unfortunately you're in the metastatic setting and you're undergoing treatment, can we use it to see if the treatment is working earlier than we traditionally would with scans? Because right now, if you have metastatic disease and you're on chemotherapy or immunotherapy, usually you should be getting restaging scans every 3 months, more or less. Here, we can potentially tell as early as 4 or 6 weeks after starting the treatment if it's working. So if it's working, great, you continue on it. If it's not working, then you're really avoiding further cycles of toxic treatment or potentially toxic treatment without really getting the benefit from it. So let's say you do get Signatera and you have negative results. What does that mean for you? If you had early stage cancer, it means that most likely we got all of it and you're more likely to remain cancer-free. But if you are in the metastatic setting and you are undergoing treatment and you get a negative Signatera, that tells us that the treatment is working and most likely you'll stay on it. If unfortunately you have a positive result and you have early stage cancer, that basically tells us with almost 100% certainty that at some point that cancer is gonna come back if we don't do any additional treatment. And when I say 100% certainty or close to it, it's because across different tumor types, not just stomach or esophageal cancer, we know that the PPV or positive predictive value of this test is larger than 98%. So out of 100 patients who might have a positive Signatera test, all but 2 patients will have recurrence, again, without any further intervention. And this is what the report would look like if you haven't seen it before. There are 3 components to it. On the top part, top left corner, you get a quick positive or negative result. Then in the bottom, you get an actual quantification. So we're not just able to detect whether the ctDNA is there or not, we're actually able to quantify it. And that has a lot of significance in tracking it, as you can see in the graph in the middle. So for example, this patient had a very high ctDNA level of 48 at diagnosis. They had surgery, it went down to 3.7. Then they started on adjuvant chemotherapy, it dropped down even further, then went to 0 and stayed at 0. So same thing in the metastatic setting. It's not just important to say if it's positive or negative, you really want to see it going down with treatment. Ideally, of course, you want to see it clear, but if you do see it going down after a round or 2 of chemo, then that tells you that the treatment is working. So how long does it take to do this test? Because we are building a test based on each tumor individually, the first time takes about 2 to 3 weeks on average, because we have to get the tissue and do the whole exome sequencing as mentioned to design the assay. After that, it takes about a week on average to get any subsequent blood draw. It takes about a week on average. So what is the significance of testing with Signatera? To summarize, one, it is a non-invasive tool to monitor your disease very closely. And I say non-invasive, even though I just said we need tissue, because we use the tissue that you already had for your original biopsy or from your surgery. We don't need any additional biopsies to design the test. Even if you had, for example, surgery 5 years ago or 6 years ago, we've designed it from tissue that's 10 years old, so it doesn't need to be fresh tissue. It can identify any cancer cells remaining in your body, even after treatment, detecting cancer recurrence early. That's one other point that we didn't really talk about before, is it can improve confidence in your scans. We see it all the time where we do a surveillance scan and we see tiny spots, say in the lungs or in the liver. And sometimes they're too small to biopsy, or they're in a very precarious location where a biopsy might not be as easy or has a very high risk. Well, if you do have those spots and you check Signatera and it's positive, that tells you most likely those are cancer spots. But if it's negative, then you can have a little bit of assurance that you continue to follow the scans, of course, and follow Signatera, but you're a little bit more assured that this could be just an incidental finding and not really related to the cancer. And as mentioned before, for stage 4, to know if the treatment is working or not. So we talked a lot about what Signatera does, but I'm going to pause here for a second and tell you about what Signatera does not do. You heard Dan talk about doing CGP assay, or comprehensive genomic panel testing, to see if a patient has a targetable mutation or changes that we can use some of the newer drugs for. Signatera does not test for that. It really looks for those mutations or changes that makes up the cancer's fingerprint and makes it extremely unique. So a lot of those changes that we use to pick treatment are common between individuals with stomach cancer. So if you want to see if your patient has, for example, HER2 mutation, then you order Altera, which is another test here in the green box. And what Altera does is it helps you identify what treatment to use, or potentially if there are any clinical trials that are looking to test new drugs that target a specific mutation. It also tests for genes that are relevant to your cancer that can impact your cancer treatment. So to take a step back and say, historically, how do we treat cancer? And then alluded to it a little bit. Well, we target the tumor and we treat all of the cancers the same way. 10 years, 15 years ago, you had stomach cancer, everyone got the same treatment. And we always had this idea that more treatment is always better. So we know that we're killing the cancer with more treatment and higher doses, but we're also damaging a lot of the healthy cells, and that's what causes a lot of the side effects. So this is traditionally what we've done. It's more of the shotgun approach, as opposed to where we're heading or where we already are, and that's the biomarker-driven therapy selection. So before we start treatment, we do Altera. We find out if there are any mutations that we can target. So instead of a shotgun, it's more of a sniper approach, or kind of a key and lock, where if you have a specific lock and you have a treatment for it, you can use that specific key rather than trying something that's one size fits all. And not just that, it doesn't just tell us whether a certain drug will work. In some cases, it can tell us if certain drugs are guaranteed to not work. So, for example, we know that if this is more specific for colon cancer, but we know if you have a KRAS mutation, then you're unlikely to respond to a group of drugs called EGFR inhibitors. So you can get that information with Altera as well. So what does that mean for you as a patient? Well, you're making a more informed decision along with your oncologist, of course, specific to your cancer. It directs the selection of what treatment to use, whether it's a new treatment or old treatment, rules out certain drugs which we know that are not going to be effective, and on top of that, identifies available clinical trials. So that's Altera. Another thing Signatera does not do is, does it tell you whether you have a genetic or hereditary predisposition to develop cancer and whether your family members should get tested or not. For that, we have the Empower test and the light blue here in the bottom. There are different variations of the test depending on what you're interested in testing, but for gastroesophageal cancer, you would check, or your oncologist would check the multi-cancer panel, which looks at 40 genes, and that includes all of the genes that are recommended to be tested for gastroesophageal cancer. So this one is a one-time test. You do it to find out, if you qualify, to find out whether you have a predisposition in your family, and that has two consequences. One, certain mutations in these genes increases your risk of other cancers. Two, for your family members to know if they are at high risk to develop certain cancers, then they can undergo screening earlier on. And if you know, they are going to get a cancer at some point, then we might be catching it earlier on. So with that, the last thing I want to show you is a couple of publications we had on showing the utility of Signatera in gastric and esophageal cancers. The first one is this study, which was published last year. It was a trial done at University of Cambridge, led by Rebecca Fitzgerald and Lizzie Smith, who are two internationally renowned gastroesophageal cancer experts. And it was a small study, only 20 patients. You'll see here on the left the breakdown. Most of the patients were male with an average age of 62, and you'll see also the breakdown by stage. 85% of the patients did receive perioperative chemotherapy, basically FLOT, 4 cycles before surgery, 4 cycles after surgery. Most of the patients underwent surgical resection. 3 patients underwent EMR or endoscopic mucosal resection because they had earlier stage cancer. And then we analyzed their survival and correlated that with ctDNA. And what we found out that patients who had ctDNA picked up after surgery, they had a much worse outcome. So the patients who were ctDNA or Signatera positive 1 month after surgery, on average, they had 14 months of disease-free survival, meaning on average, by 14 months, half of the patients had their cancer come back. On the flip side of it, patients who had no detectable ctDNA, their disease-free survival was much longer at 51 months. So even though some of those patients did recur down the line, they had a much longer survival. And that also brings up the importance that Signatera or ctDNA is not a one and done test. The same way you wouldn't do a CT scan one time after surgery and never check it again during your surveillance. Same thing for ctDNA. You need to continue to follow it because even though it might be negative early on, it might turn positive a year or 2 down the line. And there are a couple of reasons for that. One is maybe it was such a minuscule amount that it's even below the limit of detection of Signatera, or The other situation that can happen is sometimes cancer cells go dormant for months or years, and then something happens, a flip is switched, and they start growing again. So we've had cases where someone might be negative for 2 years and then all of a sudden pop up positive, and you can see the cancer coming back. I want to highlight a couple of patients from that study. The first one here on the left had stage 4A esophageal. They were treated with cisplatin and 5-FU, and you can see by the red dot at the far left that they had high ctDNA at baseline. They responded very nicely to chemotherapy because it went all the way down to 0, and they underwent resection. Unfortunately, about a month or 2 after surgery, ctDNA popped back up as positive. Now, of course, this was one of the earliest studies for ctDNA, so no action was taken. It was completely observational, meaning patients were treated according to the guidelines or standard of care, but we checked ctDNA just to correlate it with outcomes. And what we found out with the following time point, it was still positive, even higher, and eventually the patient relapsed around the 300-day mark. The second patient had stage 3 esophageal adenocarcinoma. They underwent neoadjuvant chemotherapy and radiation with carboplatin and Taxol, which is what we most commonly use in the US for esophageal and GE junction. This patient, unfortunately, even from the get-go, they had very resistant disease. So you can see their ctDNA is higher after they completed chemoradiation. It did drop down after surgery, but didn't go down to 0 completely. So what surgery did is it sort of debulked the cancer, took a chunk out, but didn't completely clear it from the body. And that's why you see it's persistently positive and then rising, and there was a confirmed relapse little over or little under 2 years later, I should say. Which also highlights the importance here of what we were talking about earlier, that not only are you detecting relapses, a lot of times you're detecting it several months ahead of anything popping up on scans, and that gives you a nice window to intervene before the cancer manifests itself. And the last thing I will show you is this poster that was presented at ESMO, the European Society of Medical Oncology, which is one of the major congresses of the year worldwide. It was a real-world data study from our own database with contributors from all across the US, top academic centers. It included 260 patients with over 800 plasma time points, 886, which means that each patient got tested 3 to 4 times. Again, you'll see the breakdown, median age of 63. The breakdown male to female is 65 to 35. And then you'll see the breakdown of where the cancer originated. Little under that half were stomach. The rest were between esophageal and gastroesophageal junction. Most of them were adenocarcinoma, and also you'll see at the bottom the breakdown by stage. And what we found out is that patients who were ctDNA negative at any time point, not just after surgery, most of them did not recur. Only a small portion of them recurred at some point down the line. On the flip side of it, patients who were ctDNA positive, most of them had recurred. You'll see that about 13 out of the entire 43 patients did not recur, which kind of contradicts what I was telling you earlier about 98%. But here's why more patients did not recur here. One, some of them received adjuvant treatment, be it with chemotherapy or immunotherapy, which cleared any molecular cancer still lurking. And 2, some of them didn't have a long enough of a follow-up where they had recurred on scans, and that's why they were counted as no recurrence. And then on the right-hand side, you'll see the probability of those patients of being recurrence-free, so alive and well without signs of the cancer coming back, you'll find that the patients who were Signatera negative had a much higher recurrence-free survival compared to the negative one. And what you'll see here between the two lines on the curve, a hazard ratio of 9. And what that means is patients who had ctDNA positive were 9 times as likely of having the cancer come back compared to the patients who were ctDNA negative, which, that's a very, very powerful tool to employ, for yourself or loved ones. And with that, I will stop sharing and hand it over to Phil.
Phil, are you ready to share your slides?
I am ready. I think actually Shirsi is going to put them up on her end and I will take control. So here we go. So thank you very much for having me, Aki. I'm honored to be here. And so I'm Phil Munson. I'm Medical Affairs Manager for Morexis, Singapore-based company. I'm US-based. And I'm going to share with you a little bit about a blood test we have for detection of gastric cancer. So I'm waiting for the screen to respond. Bear with me. There we go. So Morexis, as I mentioned, we're a Singapore-based company, and our purpose is for the early, actionable, and personalized diagnostics of disease to improve and save lives. And the way that we go about doing this is through the development of biomarkers curated by microRNA-centric devices, and also some other multi-omics technologies. But for this presentation, I'll be talking about a microRNA-centered test. And we use these tests to discover biomarkers that we can use to develop these in vitro diagnostic tests. And we know that biomarker discovery and disease detection is key to saving lives. So our base is in Singapore. We have presence in the US, myself, and a handful of others, as well as in China and Japan. And so you might be wondering, what is microRNA and why use it? And so Dan gave a great presentation on kind of the molecular basis of cancer and the central dogma of biology. And so microRNA, if you look at this visual on the right, is a very small molecule, and it comes off of DNA, but it's unrelated directly to the dogma of RNA turning into protein. MicroRNAs function by regulating how genes are expressed within the cell. And one of the keys here is, like we've heard about ctDNA, going into the bloodstream, microRNAs are also actively spat out by cells into the bloodstream and are therefore accessible as circulating biomarkers. And as I think some of us might know, or many of us know, is that healthy cells spit stuff out, cancer cells spit stuff out. And if you can use these things that are spat out into the bloodstream, like microRNAs, and assess differential expressions of those molecules, you might be able to detect disease. And that's the basis here. And so microRNAs are readily available in the blood because they're so actively secreted. And another highlight of this is that you don't need a lot of sample size. You only really need under 200 microliters of blood serum to detect a measurable amount of microRNAs. And here at Morexis, we have a novel microRNA qPCR technology for quantifying the levels of microRNA to differentiate between potentially healthy states and disease states. They're also very stable molecules within the bloodstream, and as I've mentioned, they're very measurable using our technology. So that's the central basis as to why we're using them as biomarkers. And I just hit the next button. Okay. And so the test that we have developed is called GastroClear. And so this is to aid in the detection of gastric cancer. And I need to note that it's not approved for use in the USA. So this was developed in Singapore and is currently in use in Singapore for aiding in the detection of gastric cancer. And the way that this test GastroClear works is by assessing the abundance of 12 different microRNAs within the bloodstream. And based on the levels of those microRNAs can help understand whether or not someone potentially has gastric cancer and then set them down that journey for further diagnosis. And we all know that there's a clinical need for early detection because when a disease is detected early, it's much easier to treat and save that life. And I'm just showing here at the bottom this graphic of 5-year survival rates by country. And if you look at Korea and Japan, the 5-year survival rate is significantly higher than places like China and the US. And the reason that is because they have very staunch guidelines for screening and detection. They regularly do endoscopies. So within those cultures and countries, they detect very early, therefore you have these much longer survival rates. And so this really screams to the idea that here in the US, we're lacking on early detection, and there's this clinical need for a test that can help finding the disease earlier on in order to increase survival. Now, the clinical evidence behind GastriClear, bear with me, the slides are moving slowly, not terribly responsive to my cursor. Here we go. So just quickly on the clinical evidence behind how this test was developed in Singapore. It was used with 3 main phases and published a few years ago in Gut, using a discovery phase for the development of those 12 microRNAs, a verification phase of a couple hundred to make sure that those biomarkers indeed worked, followed by a very large, nearly 5,000 patient validation phase prospectively collected to identify cancer versus non-cancer after getting GastriClear test, going on to endoscopy to find that positives were potentially or truly positive and negatives are truly negative. And so this did go through this robust clinical validation phase in Singapore using Singaporeans, Chinese populations, as well as Korean populations. And very sensitive and specific to the disease at the test's current status. And next slide, please, Shirsi. I don't think, or okay, here we go. So regulatory status, as I mentioned, it's not approved for use in the US, but it did gain regulatory approval in Singapore by the HSA in 2019. It's CE IVD marked since 2017. And there are current regulatory submissions ongoing for Japan and China. We are hoping to, at some point, start the engagements to moving forward to bringing something like this into the United States. And Shirsi, it might be faster. Could you switch to the next slide for me? Thank you. That's much faster. So the kind of quick, how does it work is that it is a blood test to then measure the quantity of these microRNAs within your blood. And it goes through an algorithm that will generate a qualitative risk score, low, intermediate, or high. And depending on that risk score, based on the measurable quantities of those molecules of microRNA circulating in your blood, it will then be used by the physician to dictate whether or not that patient should go directly to endoscopy if you fall within that high risk group. If you're within the intermediate risk group, maybe go directly to endoscopy if there is other clinical evidence. And at a low risk after this test, it can then be deemed appropriate to potentially go to endoscopy or just go for a routine checkup. And the people who are currently being assigned use of GastriClear in Singapore, average risk individuals based on age, and then other potential conditions going on like lifestyle, H. pylori, et cetera. And this, of course, is being used in conjunction with endoscopy for that true diagnosis at the end after the test. And Shirsi, next slide, please. Just the kind of summary here in future outlook is that Mirexis has developed this first blood test for the detection of gastric cancer currently in use in Singapore. And this will bolster the ability to detect gastric cancer and save lives. And so we're aiming to introduce this into the US as soon as possible because we know there's such a clinical unmet need. And we're working currently on preliminary pilot studies with research samples from US patients to see about feasibility. And we all know that these types of blood tests for detection are very promising as a solution to finding cancer early on in the hopes of shifting that paradigm of how and when gastric cancer is detected. So that I know is a very brief rundown of GastriClear, the company, and what our scope is. And I'm honored to be here, and thank you very much.
Great. Thank you, Philip. That's a wonderful overview of that test. So we've all done our talks now, and so we're going to go to the Q&A section. And there are a number of questions here that have come up, so I'll just go through them. The first one I think I'd seen, and I discussed briefly during my talk, how does one go about getting molecular profiling? And so this type of test is typically ordered by your medical oncologist, and sometimes some of the molecular tests are just reflexed and ordered by the pathologist themselves. For the most part, though, the molecular oncologist, the medical oncologist is involved. And so there are some nuances to some of these commercial tests, and maybe Adam can talk about the sort of the logistics of how a doctor would go about getting the Signatera, just briefly summarizing for the patient how they would go through that and how the patient gets the results.
Happy to. So basically, your oncologist will fill out a form that will include, obviously your demographic information, but also the tissue information that he or she wants us to test, to design the test. And then we are responsible for obtaining that tumor tissue. So it's not upon your oncologist to do that. We will track it down, bring it in-house, and then we do our testing. For any subsequent blood draws, of course, you can get it drawn at your oncologist's office, and they have specific kits for that. But we also offer mobile phlebotomy, and this really started when COVID happened, because we wanted to keep patients out of the clinic, out of the labs as much as possible. So it's a really nifty option. I've used it quite a bit for my patients, and they love it. Basically, they'll get the blood drawn at home. By the time they come and see me, they already have the results back.
Great. Hopefully that answers that question. The next set of questions is from Meka. The first one is there a real life scenario where primary tumor is HER2 negative, but then when recurrence occurs, is the tumor HER2 positive? I showed you, the answer is yes. And I showed you an example of a patient just at newly diagnosed setting of stage 4, where the primary tumor was HER2 negative and the metastatic site was positive. And actually, we've seen the reciprocal where the primary tumor was positive, but all the metastatic sites were negative. And in that case, probably HER2 therapy is not going to be as effective. So we've also seen situations where the primary tumor was HER2 negative and then had surgery, and then at recurrence was positive. It's not as common, but it can happen for the same reasons. And similarly, we've seen the reciprocal, where the primary tumor was HER2 positive at the time of surgery, but upon recurrence was negative. And that's actually common, especially if you've given HER2 therapy around the time of surgery. Then you've selected for cancer cells that are negative, and that's why they grew later. So hopefully that answers that question. And then this one is a Signatera question follow-up. Can you perform Signatera in peritoneal washing sample to detect peritoneal recurrence early, since we heard that blood Signatera has low sensitivity for peritoneal recurrence? So I'll comment on that and then ask Adam to answer. I showed you data where the amount of ctDNA is lower in the peripheral blood if you have peritoneal only cancer of the stomach. And we think that's a function of, it's not getting into the blood because it's in its own little barrier there in the peritoneal cavity. That said, we can still have cases that have ctDNA in the blood that are peritoneal only, either coming from the stomach cancer in the stomach itself, or some cancers will still get into the blood from the peritoneal cavity, especially if there's a lot of cancer in the peritoneal cavity. So that said, it is an important aspect to consider if we're using it for minimal residual disease, especially after surgery. What's the chances of finding a peritoneal recurrence versus not? And maybe Adam can talk about if they looked at that specifically in the data set, is that where you might miss it more frequently? And then the follow-up specific to this question is there a better way to do it than from the blood? Can you just do it from the peritoneal lavage or not?
No, that's a great question. And honestly, that's an area of interest for us. The short answer is not yet, because even though the technology is the same and it should work the same, obviously you have to go through the own validation trials specific for the peritoneal fluid, just to be compliant with all regulations and so on and so forth. So it's coming, but it's not there yet. Going back to the sensitivity for picking up peritoneal, as Dan mentioned, the peritoneum is peculiar that it doesn't really shed a lot of the DNA into the bloodstream. So doesn't mean that our detection is zero. It's actually, so it was reported at Society of Surgical Oncology earlier this year to be about 70% for peritoneal. So not as high as we'd like it to be, but it's not, completely undetectable. The other important thing to notice is in that study, in that presentation, not only we detected it in 70%, but when we compared the level of ctDNA coming from just the peritoneum compared to levels coming from the liver, it was much lower in the peritoneum, which again speaks to how it doesn't really shed. So yes, stay tuned. Hopefully, eventually we'll be able to run it on peritoneal.
Okay, great. So the next question is from Bela. My husband took the Signatera tests and post-op and additional immunotherapy and flat chemo. His test results were negative. That was in April of this year. But by the end of May, so a month later, he had metastases in the peritoneum. He tested positive for PD-L1. Can you discuss why his test was negative? But well, that's very relevant to what we just talked about in that you may remember the picture that I'd shown, one of the last slides that showed over time how the DNA changes. And after surgery, you'll see a drop in the amount of DNA in the blood. And often it can be below the level of detection even of Signatera. And only over time, when those cells start to grow and become bulky enough and enough DNA gets into the blood, that you will find it. And so this may be an example of where the peritoneal issue came into play. There was cancer there. Certainly there wouldn't have been cancer there a month earlier when they did surgery. They would have been able to see that and told you about it. And so if a month later or a month or two later, that was time for it to grow enough and become apparent, yet post-operatively, the ctDNA was not visible, potentially because it was in the peritoneal cavity, I would argue, and maybe because it was a low amount of cancer that was there. Hopefully that answers that. I think, Adam, we talked about that. Any other thoughts about it? No. Okay, so a follow-up that or a question that's in that chat, but maybe as a separate question, I think. In the case that tumor has a positive tumor markers like CA19-9 or whatever, what is its sensitivity compared to ctDNA in terms of detecting reoccurrence or determining response to treatment? So good question, and I'll take a crack and then lead into Adam's thoughts on it too. I mentioned that in the stage 4 setting, the second part of this question, we always follow CEA, CA19-9 over time. Usually I do them every couple of months, sometimes even more frequently if I'm worried about progression on therapy and I want to catch it early. And that said, though, sometimes these markers are normal in a given patient, even when we knew there was cancer and it was not treated. So it's not going to change. It's always normal. We sometimes still will check it periodically just to make sure it's not rising as a risk factor, as to tell us that the cancer is growing on any given treatment. So ctDNA, in my experience, is more sensitive in most patients than the tumor markers. And when the tumor markers are normal, you may still see ctDNA positivity, and then it can be used and tracked to follow over time to see if the treatment's working. I've seen, though, and I think there's a question in the chat here, where it's the reciprocal, where the tumor markers are really high, but the ctDNA is on the low side. How to explain that? It happens, and for various reasons, it could be the case that it's the location of where the tumor is, and the ctDNA is not getting out into the bloodstream as well as the protein. Who knows? It's not clear, but it does happen. So you could apply that answer also post-operatively, where we always also follow CEA and CA19-9 every 3 to 6 months through time after surgery as a mechanism of surveillance. And ctDNA now, like with Signatera, can be used. And again, I had mentioned in that one slide again, that it will often pick up a cancer 6 to 9 months sooner than these other tumor markers in the blood and CAT scans and things like that. So to me, these assays are all complementary, and they can add this sense to the sensitivity, because sometimes one's negative while the other one's positive and vice versa. And so by doing them together, you can really optimize your chances of finding things. That's how I would answer that question. And Adam, any other thoughts, sensitivity comparisons? Have you done specific studies on those tumor markers versus ctDNA, et cetera?
Yeah, absolutely. So not specifically for gastroesophageal, just because CEA and CA19-9, even though we follow them in gastroesophageal, they're not as sensitive there compared to, say, CEA in colon or CA19-9 in pancreas. So I will tell you, though, in our colon cancer studies, when we looked at comparing CEA to ctDNA or Signatera, Signatera was more than twice sensitive and specific, both at baseline, but also in detecting recurrence. Same thing for pancreatic. When we did what we call multivariate analysis, looking at CA19-9 and ctDNA, ctDNA was significant, CA19-9 was not. Same thing with ovarian, CA125 didn't really pan out compared to Signatera, which was much more sensitive. And last, I'll mention in liver cancer, hepatocellular cancer undergoing actually transplant and detecting cancer recurring after a liver transplant, AFP really didn't help as much, but ctDNA was very accurate. Kind of in the same vein, I'll address Oslam's question because it's related. So Signatera is only 0.8 and CA19-9 is 1500. So as Dan mentioned, yes. So in those cases, do you have to be cautious about, is Signatera not showing the full spectrum of the disease or burden of the disease? Definitely you want to investigate this. That being said, more often than not, now 1500 is a very high number. So I would definitely act upon it. But most of the time, we do see these slightly elevated tumor markers, and they're just so non-specific that, you know, a bunch of other causes, non-cancer related causes, can cause a false elevation of the tumor markers. I hope that helps answer your question.
Yeah, and that question was from Oslam lower down. And I think we sort of got at that. The only other thing I'd add is that in a given patient, a CA19-9 is relative to themselves. And so comparing one patient's CA19-9 to another, it's not the same. It's like comparing apples and oranges, and it's all relative. Same thing with ctDNA. That 0.8 is positive. And so it's the tracking over time to look at up and down that really matters, not the absolute value. So, for example, the next draw might have both of them up to the same same percent increase, and that would be concordant with growth. But their absolute value is not necessarily as important as the changes over time, I think I would say. And along, no, go ahead.
Yeah. One more nuance here is it really depends on where in the cancer journey those values came about. So if this was, for example, right after surgery or right after, let's say, chemotherapy, I'm not sure if that's the situation here, the CA19-9, CEA, AFP, they have a longer half-life, so it takes longer for those numbers to come down and normalize compared to the 1 hour or so that we talked about with ctDNA.
Yeah, that's a good point. Usually, I would never check a tumor marker for at least 4 to 6 weeks after surgery, if not longer, to get so that we don't run into that trouble. And we're looking in the adjuvant setting. Okay, and I'm going to use this opportunity to ask Phil from Morexis regarding his assay, which he was talking about is being developed to look at an early detection scenario. But Phil, is there any effort to using the same technology for these questions we've just been asking, like, is the cancer there after surgery a residual amount, or can we follow this test over time as a monitoring tool, either after surgery or during chemo in the stage 4 setting? Do you see application there, or is it really solely for screening at the moment?
Yeah, so that's a great question, and it's definitely something that we are thinking about at the moment. The test is not approved for it. We can't do that yet, but we're thinking about it, and we know the need. And what I can say is that it is potentially useful in this type of setting, but we don't have data yet to support it. And the other thing is that it might be the test as it is, but there's very likely a chance that in circumstances post-surgery and monitoring over time that we might also alter the microRNAs we're looking at. So it could end up being a different test just using the same technology. So we're definitely looking into how it could potentially be used for this type of case, but at the moment, not sure, but absolutely there is potential for it, and it could be the same set of microRNAs or different, but we need to kind of finalize how that will look. And I will also say just very quickly, I see Greg had asked a question about intervals of testing, and how many tests do you need to do to get meaningful data, and how long between each test, and that's also a great question. And what I can tell you is that getting one test will provide you meaningful data because it will give you this risk score. So you can rely on a single test being meaningful. As for how many tests you're going to need, you would want to get, I mean, that's something that you'd have to rely on your physician to help guide you through. And that's not something I would necessarily know. I think it's going to be dependent on each individual patient and how that physician guides them along. And the length between each test, again, guided based on risk and what your physician says. But that's basically where it sits.
Got it. Good. Okay. And then just as a follow-up, Oslam put in the chat there that his situation of that high CA99 was a year after the surgery. So it's not likely to be a half-life issue, but probably high. Assuming it was checked earlier and was in the normal range, this would be in the high. And your ctDNA is positive too. So, I don't think there's a discrepancy in terms of the results. Going back up to the top, Dean had asked a question, which is interesting. I'm interested to hear the result, what Adam thinks about it, is that what would account for a drop in the ctDNA levels after an initial positive, but not having any treatment in the interim? It dropped from 0.22 to 0.13 to now 0.09, not having any treatment. I'm not sure what the time intervals between that, but let's assume it's your regular checks. How often do you check, Adam? This might be a good time to say that.
Yeah, no, great question. So usually we say wait at least 2 weeks after a surgery or any chemotherapy or immunotherapy, minimum 2 weeks. Usually we say 2 to 4 weeks. 4 weeks is kind of the sweet spot. And then after that, you can do it every 3 months for 2 years, then every 6 months. Now, why would it drop on its own? So there are two things to highlight here. One is the actual level. So it didn't drop on its own from 20 to 5 to 1, right? It went from 0.2 to, I forget what the numbers are, but it's pretty small. So even if you check a regular CBC 5 times in 1 day, you're not going to get an exact, say, white count of 7 on the dot all 3 times. You're going to get a 7.2, 6.8, 7.1, etc. So there's going to be a little bit of variation. Part of it also depends on what time of the day it was drawn. So there is a little bit of a diurnal variation in the ctDNA shed. We think it might be related to potentially cortisol levels higher up early in the morning and causing higher shed. And last, I'll mention something which has not been proven, but all of us in the field think it might be one of the reasons is we all have immune surveillance in our body, right? So all of us throughout our life, we develop some sort of cancerous cells, but usually our immune system is good enough to clear those cancerous cells. When cancer kind of gains hold and becomes cancer as we know it, it's when the cancer cells overwhelm our immune system where it's not able to keep up with it or clear it. So what could potentially happen sometimes, and this has been shown very well with melanoma and kidney cancer, is if you debulk the cancer, meaning you take the largest chunk of the tumor in the body, you remove it, sometimes the body is able to clear a low level of disease staying in the body. Again, I'm not saying that's definitely what's going on here, but we do see it sometimes where after surgery, the Signatera might still be positive low level, then 3 months or 6 months down the line, it clears. But again, here you're talking very low level.
And Dean's answering some things in here. So it sounds like it had been a couple of years since surgery, then that first positive, and then now these have been checked every 3 to 4 months, and they're sort of hovering in that level. And so I can see, and I'm guessing there's nothing on scans, if you can confirm that or not, Dean, but so this might be a dilemma now that everyone's deciding, what are we going to do about this? Especially it's not rising, but it's there. And this is the issue with this now. We're learning about this, and what are we going to, the first question we might ask is this real? And my guess is that it is, but is there a false positive rate? Should we talk about that? What is it, and what the test show?
Yeah, so like any test, nothing is 100%, but the false positive rate is less than 2%. So the fact that he was negative though for multiple time points and then it popped up positive.
Right. And now it's always positive. And now it's positive 3 times. So I'm worried about that. But, you know, before ctDNA came around, we long used CEA and CA19-9. And there are cases that I would check it and one or both of those would start to become elevated, abnormal, but CT scans, PET scans, endoscopies, all normal. And what do I do? What am I going to do? And so basically it's, let's wait it out. Maybe we'll change the interval of screening to see you from every 6 months down to every 3 months, just to catch things earlier and follow things closer. And then, you know, I've had cases that went on like that where the tumor markers kept going up slightly over time, but I still couldn't find where it was. And then eventually, you know, it comes to light on a scan or through symptom or through endoscopy or a combination of that. So, you know, the real question is, does finding it even earlier now with ctDNA, because that's going to predate it by 6 to 9 months, do anything different for us? And so I think that's a big debate, opens a can of worms, but in some cases it might make the doctor look even closer and find it and maybe be able to do something about it. Like in Camilla's case earlier, where maybe that heralded the peritoneal disease. Otherwise we wouldn't have seen it until it was much more advanced and maybe more symptomatic and things like that. So that's a really important question, Dean, and hopefully that sort of gives you some answers on that. The next question is from Greg. My oncologist recently stopped looking for tumor markers in my blood. Yeah.
Let me just make one more comment for Dean's case, because I saw he replied as clear scans. So what we recommend in this situation is you should, or your oncologist, you should continue doing scans, I would say every 3 months, because what happens, and I've had those cases in my clinic where you see ctDNA pop up positive, you do scans, nothing shows up. But what I've done is I've made the interval between scans shorter, so every 3 months, and almost always something pops up. And I've been lucky where I've been able to detect it, where, as Dan mentioned, it's only 1 or 2 spots and you can still go for cure. The other thing to note is also how fast the ctDNA is rising, or if it's staying about the same level, also gives you an insight on the tumor biology. So the one we have seen it, especially in colon cancer, where we see like the upswing if ctDNA is rising, where it's a really steep upswing. That usually tells you that the cancer is moving fast and replicating quickly, versus ones that might be up a little bit, down a little bit, kind of hovering around a line. Those ones are usually kind of slower moving or more indolent cancers.
Great. So Greg had a question in his case. His doctor checked tumor markers at diagnosis pre-surgery, and even there they were normal, like we've been talking about. In some cases that's the case. And then I had a stage 2B, then surgery was stage 3 with lymph nodes positive, and now in surveillance. And so the question is, could he still possibly benefit from getting ctDNA testing done? I would argue yes, because we've just mentioned that, ctDNA can be more sensitive than tumor markers, and also they're complementary. Sometimes one's positive and the other one's negative. So, depending on how long you are out from surgery, you could consider doing this as another mechanism of following and surveilling the cancer. They would go back to, Natera would go back to your surgical sample to get the tissue to identify the mutations to go after, and then check your current blood draw to see if there's any evidence of that DNA floating in your blood. Do you agree?
100%. And actually, one of the cases I just mentioned that I was lucky to pick up cancer coming back early, he came to see me for the first time 1.5 years after he was treated elsewhere for anal cancer. So I checked ctDNA and it was negative the first 2 times. Then he popped positive and nothing on the scans, and eventually got an MRI upon the inguinal lymph node and resected it. Didn't give him any chemo. ctDNA went back to 0 and stayed at 0. So yeah, the short answer is yes. I think there's tremendous value to add here.
Okay. We have Denise asking, if the tumor is still large enough to see on a scan and treatment is trying to shrink that, would the doctor still prefer a CT scan over Signatera to monitor if treatment is working? I think that my answer to that would be similar to, should we monitor tumor markers or Signatera or any ctDNA assay in the stage 4 setting? And I think they're complementary to each other, that CT scans have been the traditional way to follow things objectively, other than with symptoms and how you're feeling, is your swallowing getting better type of thing. And also tumor markers, which trended to the right direction, they go down if it's working. So together though, in addition, another layer with ctDNA can just give me more information when I'm treating my patient to know if a patient's tumor is progressing or not. Sometimes CAT scans are sort of equivocal. We can't tell. So the tumor markers are not useful. And we just don't know if a patient is having they're not feeling well, but we don't know if it's a side effect of the treatment or if it's from the cancer getting worse. And this is a common problem with gastric cancer. So ctDNA has often helped me to differentiate between not feeling well because of side effects of treatment and from the actual cancer growing. And in the example where it's from the cancer growing, the ctDNA would be going up. If it's in the example of where the cancer is not growing or it's well controlled, the ctDNA is much, much lower than it was long before when you started this therapy. And that gives me a clue that maybe it's from the treatment that's making you feel this way. So I think that adding it to the standard way of doing things, at least for now, is what I would advocate for. Any other thoughts or additional things there? No.
It's an additional tool in your tool belt.
Yeah.
Eventually, will we get to a point where we would only do a scan if ctDNA is rising? Perhaps. Studies are ongoing, but right now we don't recommend to replace CT scans with Signatera. It's just an additional piece of information to help guide you.
Right. The next one we've answered from Oslam. The next one from an anonymous attendee who joined late was asking, I've been through all these treatments and I'm in remission. How can this testing help me? Hopefully you've heard the last little conversations is that it can help understand, adding to CT scans and blood markers and how you're feeling, whether or not there's evidence of an early recurrence or not, and whether one can act on this information. Iris is asking, similar to the tumor markers rising question, while blood tests are not, should we consider CA19-9 to be accurate? So the ctDNA test is not rising, but CA19-9 is. In your case, if that's what's happening, what I would argue is that I would be worried that the CA19-9 is going up and continually rising. And we see cases where we talked about in my talk where some tumors just don't shed DNA, even in the overt stage 4 setting. And it has to do with where the tumors are located, like the peritoneal cavity. And so, we use all this information and then we make a judgment whether or not we think we should act on it. And so I would look at scans, I would look at endoscopy, I would look at how you're feeling, I would look at tumor markers, and I'd look at ctDNA. And if the balance tips in favor of me feeling like this looks like there's progression or recurrence, then I use all that information to make that judgment. So in your case, if CA19-9 is continually rising and you have a known gastric or esophageal cancer, that is concerning no matter what other tests are saying. And then can any of the tests discussed be used to predict reoccurrence after, say, 4 to 10 years? There's no time limit per se, other than I would argue that we quote 5-year survival rates because the chance of the cancer coming back after that time point are very, very low with this type of cancer, gastroesophageal cancer. Breast cancer, for example, different, can come back 10, 20 years later. But in this case, it's never a 0% chance, I tell my patients at the 5-year mark, but we do celebrate because the chances are extremely low. And so is there need to check at that late time point would be the real question you should ask. And because the chances of it coming back are extremely, extremely low at that point. Never zero. I've seen some weird cases, but it is unlikely, let's put it that way. But that's not to say that this could find the recurrence. This technology doesn't have a time limit to it. And so even though the surgery was 6 years ago, you could still go back to that sample, get the information you need, and then design your blood draw and address it. The only difference might be is that the cancers may evolve and change and not have those mutations anymore. But that's why I think Adam had mentioned they use 16 different choices to prevent that problem. So even if you lost half of them, you still got the other half type of thing. And then the last question here, which is good timing because we're going to close in 3 minutes, is that isn't the Signatera integrity accuracy affected by ongoing chemotherapy, particularly when the chemo cocktail is being changed during the treatment? Should treatment be suspended or paused for the test? That's a good question. And if so, how long? So this is a good question in terms of, I was mentioning and showing you the graphs where if you have therapy and it's effective, that there will be a drop in the ctDNA in the blood. If you remove the cancer surgically, of course, there will be a drop. You're removing the cancer that's putting the DNA into the blood. And so I guess the first question would be is, why are you checking the ctDNA? Are you checking it to identify genetic events so that you can pick a targeted therapy? Then you would want to try and optimize the blood draw timing around a time point where the chances of the ctDNA levels are going to be high, like before you start treatment or at the time that your treatment has stopped working. Then you don't have to wait per se because the cancer cells that are resistant to the given treatment are growing. And so it doesn't matter that you're still on that treatment, it's growing on it, and we should be able to see the ctDNA in the blood. If your intention is for monitoring to see if the therapy is working, then you could check it anytime you're concerned, or if you want to make yourself feel better that it is working. It doesn't really matter when you check it, because when you check it, if it's low negative, that's telling you it's working, the treatment. And if it's not low negative, or if it's rising from higher than the prior time you drew it, then it's telling you that in the interim, the treatment you used was not effective because the cancer DNA is getting higher in the blood. So those are all important questions, but again, it depends on what your intentions are for checking it. Again, if you want to find what the genetic problems are, then you want to try and do it at a time point where the likelihood of finding DNA in the blood is at its highest time point before treatment or at the time of resistance.
Yeah, exactly. I would add to that typically we say at least wait 2 weeks after you received your last dose of chemotherapy before checking it. So if your regimen is every 2 weeks, so we ask that you check it, the day you go to receive your next cycle or just before you receive it, obviously. If it's, every 3 weeks, then that's even better. And the reason that has to do, I'll wrap up real quick. Remember, we talked about that needle in a haystack. So while the patient is on chemotherapy, the chemo also damages normal cells, as he said, and releases more of that non-tumor cell-free DNA. So the haystack gets bigger and bigger, which can affect the performance of the test. But 2 weeks after the chemotherapy, we believe that we should be able to detect it with very decent sensitivity.
Great. Well, all the questions are answered and it's right on time. So I'll just close out the webinar here and thank Adam from Natera and Philip from Mirexis for joining us and providing backgrounds on their assays. And hopefully you found this useful, and thank you for attending.